Now that we've reviewed hemostasis, let's talk about the drugs that can be used to prevent clotting. So if someone has an abnormal clotting disorder or they have high risk for a clot, we can give them an anticoagulant, which would be the class of medications to block the formation of that clot by blocking the clotting cascade. There are a number of drugs in this class, and we will touch on these a little bit more specifically and detailed than we did with antiplatelets, since the therapeutics for these medications will begin on day 3 of cardiology. So as you can see, there are heparin products, synthetic pentasaccharides, one in particular, direct anti-factor Xa that work directly against factor Xa, direct thrombin inhibitors, and a vitamin K antagonist. So to begin with, let's look at that beautiful cascade again and see where these drugs play a part. We have vitamin K antagonist, that would be our warfarin, that is working at blocking the vitamin K epoxide reductase enzyme. That enzyme is required in the activation of vitamin K to its reduced form. That reduced vitamin K is important in the formation of factors 2, 7, 9, 10, and don't forget protein C and S. So our vitamin K antagonist is not blocking the activation of these factors, it is actually blocking the formation of these factors through vitamin K epoxide reductase inhibition. So we have factors 2, 7, 9, 10, protein C and S are all inhibited by vitamin K antagonist warfarin. We have a direct thrombin inhibitor class. These all work directly against thrombin. So that's pretty easy. If you know the name of the drug and it fits into that DTI class, you know what factor those drugs are affecting directly. So these are direct thrombin inhibitors. Anti-factor Xa medications are somewhat new to the class of anticoagulant therapies. These direct anti-factor Xa drugs, there are 4 in class now. They work directly against factor Xa. So they do not require anything other than the drug blocking factor Xa. That's different from one of our heparin products that similarly blocks vitamin or factor Xa, but not directly. So direct anti-factor Xa drugs block directly at factor Xa. Our unfractionated heparin, remember that all of our heparin products do require antithrombin 3 in order to potentiate the activity of the antithrombin 3 against specific factors. Unfractionated heparin has no preference, so it can block 10A and 2A equally. It's an equal opportunist. It can also affect the factors all the way up through the intrinsic cascade. So here we see factors 2A and 10A, which are at the bottom of the cascade, are blocked by unfractionated heparin, potentiating the activity of antithrombin 3. That can also affect the other factors within the intrinsic pathway, but most physicians and honestly most pharmacists will really only recall that unfractionated heparin is blocking factors 10A and 2A through the antithrombin 3 potentiation. Low molecular weight heparin becomes a little more selective, so it has big 10A and little 2A. So I think like big 10, little 2. There is the majority of the activity of low molecular weight heparin will bind to antithrombin 3, potentiating its activity more selective for 10A and does have the ability in some capacity to block at 2A as well. But just like unfractionated heparin, if we don't have antithrombin 3, these drugs are not working at all. And then last in the heparin-like properties would be our synthetic pentasaccharide. There's one drug in this class, fondaparinux, that is branded as Arixtra, which we'll get to. And the way that this synthetic pentasaccharide binds to our antithrombin 3 makes it exclusive for activity against 10A. This synthetic pentasaccharide is binding to antithrombin 3 and causing antithrombin 3 to become selective against 10A. So let us move into our heparin products. We have unfractionated heparin, which you'll recall is the most commonly prescribed and utilized parenteral anticoagulant. However, we have new parenterals added to that class. So although this was historically the mainstay of therapy, it is now opened up to include low molecular weight heparins and our synthetic pentasaccharide. So unfractionated heparin is a mixed bag. It does potentiate the activity of antithrombin 3. So if antithrombin 3 were not there, unfractionated heparin would not have the ability to anticoagulate the system like it would if we have an abundance of antithrombin 3, as we do in a normal healthy population. Antithrombin 3 is also made in the liver. So that if we have severe liver disease, we may have a decreased ability to produce antithrombin 3. And that becomes a controversial concept as to whether anticoagulation is necessary in those populations. In any regard, we know that unfractionated heparin potentiates the activity of antithrombin 3 and most specifically works against factors 10A and 2A, as bolded here on the slide. We do get a conformational change of that antithrombin 3, which catalyzes the activity and causes it to become more potentiated in binding factors 10A and 2A. Unfractionated heparin, different from some of our other drugs, is measured in weight in units, not in milligrams. Unfractionated heparin in units was calculated using sheet plasma, and we now have units that regulate how much of a dose the patient is receiving. It is administered through subcutaneous most often for prophylaxis, and then we can use IV or subcutaneous administration for therapeutic dosing in treatment of clots. It is the safest drug to use in pregnancy and lactation, and it can be used during labor and delivery, different from some of our other drugs that are also noticed to be safe in pregnancy. So we have unfractionated heparin can be administered through IV or subcutaneous, and it is safe in pregnancy and lactation. For the first cardiology assessment, assessment 2.3, you are responsible for understanding and recalling the dosing for venous thromboembolism, so VTE treatment and prophylaxis dosing. And here we see that there is unfractionated heparin can be used in both VTE treatment at 80 units per kilogram IV bolus, then 18 units per kilogram per hour continuous IV infusion. Or if we skip down to VTE prophylaxis, you could administer that as 5,000 units subcutaneously, either twice daily or 3 times daily. The unfractionated heparin for any of the ACS, so unstable angina and STEMI treatment dosing, is not going to be assessed on assessment 2.3, but will be carried over into assessment 2.4 with Dr. Bhakta. So as far as dosing goes, we will cover it also in cardiology day 3, but for all of your anticoagulants listed here, you should know VTE dosing for the assessment 2.3. Unfractionated heparin is most commonly monitored using laboratory evaluation with activated partial thromboplastin time, abbreviated APTT or PTT. What we're looking for is a therapeutic range of 1.5 to 2.5 times the normal level of APTT. Unfractionated heparin can also be monitored using an anti-factor 10A level. And if you do draw that level, your therapeutic range would be considered 0.3 to 0.7 international units per milliliter. You can also monitor unfractionated heparin at bedside using an activated clotting time. However, a reference range is not provided here. So you can monitor unfractionated heparin with APTT-PT. You can monitor unfractionated heparin with an anti-factor 10A level, or you can monitor unfractionated heparin with ACT. For the general ADRs to this medication, all the drugs in this material will cause bleeding. That's what they're being used for, is to promote or to block clotting, which will then enhance bleeding. But more specifically with unfractionated heparin, we do have a concern for thrombocytopenia that is related to the drug. We have 2 different differentiated ADRs. One is HIT, heparin-induced thrombocytopenia, which we will learn in more detail in just a second. And we also have HAT, heparin-associated thrombocytopenia, which is less concerning. Osteoporosis is also noticed with chronic use. This would be long-term use So that is important as we get to the end of the year when we're talking about men's and women's health and the aging population. It does have drug interactions with any other drug that we talk about in this material. However, it is not an absolute contraindication, and often we do co-administer antiplatelets and anticoagulants as we may deem them necessary for certain conditions, and we'll get to that with our therapeutics. Low molecular weight heparins are very similar to heparin, other than we've reduced or filtered out the long strands. So here we see our low molecular weight heparin has a 5-sugar sequence that we are binding to, and we also have this long chain or tail that is attaching to the antithrombin 3. That antithrombin 3 tail will make the low molecular weight heparin most selective for 10A. However, it is a mixed bag. So sometimes we get longer or heavier molecular weight heparin, and then that would make it or potentiate the activity of antithrombin 3 to be able to inactivate factor 2A. But when we talk about low molecular weight heparins, we are talking more specifically about their selectivity for 10A using antithrombin. They do have the ability to block 2A as well, but not as common. Low molecular weight heparins must be administered parenterally, and specifically you can inject low molecular weight heparins through subcutaneous administration. These are safe to use in pregnancy, but not safe to use during labor and delivery, surrounding the risk for epidural and spinal hematomas. So similar to unfractionated heparin, they are safe to use in pregnancy, and actually low molecular weight heparins are the most preferred during the pregnancy. However, when the woman is about to deliver or scheduling a delivery, they will switch back to unfractionated heparin during labor and delivery to reduce the risk of spinal and epidural hematomas. There are 3 low molecular weight heparin medications that you are responsible for. The first of these is enoxaparin, branded as Lovenox. You will notice when you get out into clinical practice, this is the most commonly prescribed and utilized low molecular weight heparin that is currently available. This has 2 different dosing strategies. One is for VTE and ACS treatment, as well as we have VTE prophylaxis dosing. You'll notice that the VTE treatment dosing is weight-based, and then the VTE prophylaxis dosing is fixed dosing. There are renal adjustments required for Lovenox. Next we have dalteparin, branded as Fragmin. Fragmin is available for VTE treatment as well as prophylaxis. You will notice that this is measured in units rather than milligrams. So dalteparin Fragmin is measured in units. We have weight-based dosing for VTE treatment and fixed dosing for VTE prophylaxis, with renal adjustments required also. And finally, we have tinzaparin, branded as Inohep, as our 3rd low molecular weight heparin. This is available for VTE treatment and prophylaxis. It is measured in units. We have weight-based dosing for treatment, fixed dosing for prophylaxis, and this also requires renal adjustment with reduced creatinine clearance. For all low molecular weight heparin, we should be monitoring serum creatinine to evaluate the creatinine clearance of these patients. We could also be looking at platelet count, since these do have the potential to cause HIT, more specifically with their treatment dosing. So we do monitor platelet count while they're inpatient, but if these patients are outpatient, they're probably not going to be followed as continuously as they are in the hospital. So we don't generally monitor too frequently when they're in an outpatient setting. There is the ability to monitor anti-factor 10A with these drugs. However, this is not done routinely. It is not recommended in your average patient population. It is most specifically used in special populations. Specifically, they talk about it with pregnancy, with severe renal impairment, and possibly our obese patients that we are not sure if it's over anticoagulating because they have a higher volume of distribution and higher dose. If we are monitoring anti-factor 10A, we do have specific therapeutic levels, which should be drawn 4 hours after that dose, and you would be responsible to understand that it should be at least 1 or higher. So looking at enoxaparin as our guide, therapeutic levels for our low molecular weight heparins using anti-factor Xa should be higher than 1. The ADRs for low molecular weight heparins, all 3 drugs in this class, include bleeding. There's also the risk of thrombocytopenia, however, it is much lower than what you would see with unfractionated heparin. In fact, we really only see it, if at all, in our therapeutic treatment dosing of these drugs. So we have lower incidence of heparin-induced thrombocytopenia. We do have drug interactions with all of the antithrombotics. However, you may see the use of these in combination when therapeutics require it. There is a significant black box warning, as you'll see with a lot of these drugs, for hematoma risk with epidural and spinal puncture. And so if you recall, low molecular weight heparins can be safely used during pregnancy, however, should be avoided during labor and delivery time. That is commonly related to the hematoma risk. So most pregnant women, as they're entering the hospital, are wanting to have an epidural or a spinal puncture, or may necessitate the use of those therapeutics. So we want to avoid these drugs surrounding labor and delivery. In any event where the patient may have to use epidural or spinal puncture, we want to avoid low molecular weight heparins. Both unfractionated heparin and low molecular weight heparin have a reversal agent, notably protamine. Protamine has high affinity towards heparin products. It is derived from salmon sperm, which is why a number of students will remember it since it's quite unique. But protamine of itself is a natural anticoagulant. So when we're dosing it to reverse the effects of heparin or low molecular weight heparin, we only want to use it reservedly to the dose that is required to reverse the amount of heparin that we can anticipate in the bloodstream. So when we administer protamine, we're very conservative with the dosing, and we only give just enough protamine as to bind to the overdosed heparin or low molecular weight heparin in order to reverse that anticoagulant activity. If we were to overdose the protamine, however, we would actually cause more bleeding, which is what we're trying to oppose with the protamine. So we want to be careful with how much protamine we're actually administering. As noted, protamine is really only partially effective in reversing low molecular weight heparins, but it has high affinity for unfractionated heparin. So we want to be just careful of how we're using the protamine to reverse our heparin products. You are not responsible for this dosing, but I want you to understand that we use the lowest dose that's recommended based on the timing of the last dose and the type of drug that was administered and the dose that was administered. So we do have a calculated table here that takes into account when the last dose was given, what drug was given, and what dose of that drug was given as to how much protamine we should give. We can never maximize out as much protamine as we can give in a max dose. It is the limited, conservative dosing that we use in reversing our overdosed heparin or low molecular weight heparin that we've administered. This is a reversal agent, so not to be confused with any other ADR. If we overdose our heparin products, we can use protamine to reverse the heparin effects. Different from an overdose, we do have 2 different ADRs that we have mentioned already. Heparin-associated thrombocytopenia is a drop in platelet count. This is not a significant drop in platelet count. It is just a noticeable drop in platelet count. We generally just watch and wait in this case. So we continue the heparin products. We do monitor their platelet count, and within days they have spontaneous resolution of their platelet count. No harm, no foul, just continue the heparin therapy. This is differentiated from heparin-induced thrombocytopenia, HIT, which is, again, not common but serious if it does occur. This is a significant drop in the patient's platelet count that is associated to an immune response to our unfractionated or low molecular weight heparins. If the patient has had previous exposure, like any immune-mediated response, you would have more abrupt or immediate response to cause the platelet counts to drop. or if they're completely naive, the patient may have a delayed reaction. So the immune response is delayed in our naive patients that is extended out to 5 to 10 days of therapy. So if this is occurring in day 1, the patient has never seen a heparin product before, we're not concerned about HIT. We may be considering, is it HAT? If the patient has a delayed reaction, that is more concerning for HIT in that naive patient population. So it's important to know the history of the patient in determining the timing of this administration and the drop in platelet count. The third T that is also potentially noticed is thrombosis. The drug we know is an anticoagulant. It is meant to anticoagulate and reduce the risk of clot, but in patients who experience HIT, they are at higher risk for a clot, and if we do see signs and symptoms of new or worsening clots, this would be the sign of thrombosis. Those 3 T's are present in HIT. They have thrombocytopenia. It is the right timing related to the administration of the drug and the patient's history of exposure to heparin products, as well as new or worsening clots or thromboses. In the case of HIT, we do not mess around. We immediately discontinue the heparin product. We can evaluate using a 4T score, which we'll get to, or we can also do objective measures using IgG or SRA tests, which we'll get to also. We do have a patient that has an existing clot. That's why they were on the anticoagulant to begin with. They were on heparin or low molecular weight heparin to treat an existing clot, in which case we do still have to anticoagulate that patient in order to prevent that clot or these new clots from getting larger, and we do typically convert directly to a direct thrombin inhibitor. So we will be familiar by the end of today with how we manage these patients that experience HIT. I'll use this slide to talk through the pathophysiology of HIT. It is a little bit confusing, so I'll try to simplify it for you. If we begin at the top of the image on the right at position number 1, you will see that we have platelet factor 4, the PF4 complex here, as well as heparin available in the circulating bloodstream. Platelet factor 4 is released from platelets upon activation, and it's just freely circulating in the body, as well as the heparin will be freely circulating when it's administered parenterally. The two of these complex together to form a platelet factor 4 heparin complex. Those complexes then start an immune response within the body, so they trigger an IgG antibody production. IgG antibodies then attach to the PF4 heparin complex and form an immune complex of all 3 combined. So we have the platelet factor 4, the heparin, and the IgG antibodies all complexing together. Those antibodies with their Fc attachment will allow that complex to then bind to the platelet's Fc receptors on the surface of the platelet. Those will further activate platelets, causing further release of these PF4, platelet factor 4 substances from the platelet surface, causing a perpetuation of this process where we have more and more PF4 being released as platelets are being activated and thereby aggregating very quickly. The platelet activation and aggregation will deplete the platelet counts in our body, as well as the PF4 in abundance will start to bind to heparin-like molecules that are available on the endothelial cell linings of the vessel. These endothelial cells have natural heparin-like molecules that are attached to their endothelial lining cells. The PF4 will come in contact with these heparin-like molecules, binding to them. Then the available IgG antibodies will then complex with these complexes at the endothelial lining cell level to cause vessel damage. Those vessel injuries that are happening all over the vessel wall will further cause more thrombosis risk. So patients that are developing HIT will be at risk for a drop in platelet count as those platelets are activating and aggregating. We know that aggregated platelets cause thrombosis. As well, they are releasing excessive amounts of platelet factor 4. That platelet factor 4 will bind to heparin-like molecules that are available on the resting endothelial lining cells, as noted here on a blood vessel. Those will further potentiate the complexing of IgG, PF4, and heparin-like molecules at the endothelial lining, causing vessel injury, thereby potentiating the production of thrombosis. So patients that are experiencing HIT will have a significant drop in platelet count as those are activated and aggregating and being eliminated, as well as they will be at risk for increased thromboses occurring throughout the body. Here is another pictorial image of that. We have PF4 being released from the platelet. That PF4 then can complex with the heparin that is also available in the circulating bloodstream. That heparin, PF4 heparin complex will signal the immune system in this patient to manufacture antibodies, most commonly IgG antibodies. Those IgG molecules will then connect with the PF4 heparin to form a PF4 heparin IgG complex. This complex then will signal the activation of further platelets or neighboring platelets. So a number of our platelets become active. As we get activation, we are then potentiating clotting. So we get platelet activation leading to thrombosis. The patient is hypercoagulable and their platelets are used up within these clots, so they get thrombocytopenia. Another way that we can evaluate and diagnose HIT is those 3 T's. So we have thrombocytopenia is our first T, and that can be scored based on the significance of the drop in platelets. So we have a score 0 through 2, where higher is higher risk for HIT. We have the timing of the platelet drop. So if the patient has never had exposure to the heparin product, then we would expect that onset to be delayed. If they have had previous exposure within the last 90 days, more specifically, then they will have that occur on day 1. So immediately upon re-exposure to the heparin product, they will experience a significant drop in platelets because their IgG is already ready and waiting for the complexes to occur. The third T is thrombosis. So we have an increased risk for clots. They are hypercoagulable with the PF4 heparin immunoglobulin complexes. So we get either expansion of the existing clot or a new clot, or even suspected thrombosis would raise concern. And then the last T is other. So the T here is capitalized. Any other causes for thrombocytopenia will reduce that score. If they have no other cause for HIT or the thrombocytopenia, then they would have a score of 0. So if they would have a score of 2. So no other cause will give them a higher score. Any possible cause will decrease that score. In any regard, we add up the total score for the different 4 T's. And if their 4T, as seen down here below, is less than 3, they have low probability for HIT. If it's 4 to 5, it's intermediate, and anything 6 or higher is high probability of HIT. If we have a high probability of HIT, we're already discontinuing the heparin product and converting them over to argatroban, which is our direct thrombin inhibitor. If we want to confirm our 4T score, we could use laboratory confirmation. That would be either an ELISA for that complex. So that would be an IgG antibody. It's evaluating antibodies related to the heparin PF4 complex IgG. And we could also use serotonin release assay. It is not routinely done. However, if they want to, they can do antibody testing or they can use serotonin release assay. They do not need both to confirm. So when are the other would confirm, but remember, if they have high probability for hit, they're already discontinuing the heparin product and converting them over to argatroban, our direct thrombin inhibitor. So that is it for our heparin products. This next class of drugs, synthetic pentasaccharide, is our heparin-like product. So similarly, it has a 5-sugar sequence that binds to our antithrombin 3. But in this case, it is just that 5-sugar sequence that's binding to the antithrombin 3. When we have that short strand of 5-sugar sequence being bound to the antithrombin 3, it causes the antithrombin 3 to become exclusive for just factor Xa. So fondaparinux, branded as Arixtra, is just working on antithrombin 3 to potentiate its activity against factor Xa. This is different than our direct anti-10As, but it is exclusive to 10A. We have just the one drug in class, fondaparinux, which is branded as Arixtra. You'll notice the X in the name. That's always helpful. So fondaparinux Arixtra is our synthetic pentasaccharide. It is administered subcutaneously, and it does have renal consideration for dosing. Here are the indications as well as the dosing strategies for the different therapeutics that we'll be talking about starting in day 3 and beyond through Cardiology 2. Fondaparinux does require some monitoring. Remember, in an inpatient setting, they may do this more frequently. In an outpatient setting, this is done routinely, but certainly not every day. So we do want to monitor serum creatinine for any drug that's administered that has a renal adjusted dose. So we should know what the renal function is in this patient. And we always monitor for signs and symptoms of bleeding in any of the drugs on this class, or in this packet, really. Adverse effects are bleeding, and very nice to say there are no reported hit patients on fondaparinux. So fondaparinux, although it's not FDA approved and not labeled for use in HIT, it is appearing in the guideline as an option. However, we do teach, or I teach, that argatroban is your drug of choice when a patient experiences HIT to convert to argatroban. That is the safest, most documented, effective way to anticoagulate a patient who's HIT positive. However, you will see potentially clinically that fondaparinux has a place in therapy in our HIT positive patients, since we have no reported cases of HIT while using fondaparinux. And it's certainly cheaper, and it's subcutaneous, which is different than the argatroban. Drug interactions, as I mentioned, will be any other drug in this packet. However, we may consider combination therapy based on the therapeutics that we're treating. Here is a figure that will show you the differences between our heparin-like products. So we have unfractionated heparin A in the top. That potentiates the activity of antithrombin 3 to become semi-selective but equal opportunity. It can bind to either 10A or 2A pretty equally, so we don't have selectivity with unfractionated heparin. With our low molecular weight heparins in the middle, figure B, we have a shorter strand that causes the antithrombin 3 to go through a conformational change, making it more selective for 10A, so big 10, little 2. It does have the ability to also potentially inhibit 2A, but almost exclusive for 10A here. In our figure C, we have pentasaccharide. We have our synthetic pentasaccharide, fondaparinux, branded as Arixtra, that binds to the 5-sugar sequence on the antithrombin 3. That makes the antithrombin 3 go through a conformational change where it is exclusive for activity against factor 10A. So all 3 of these drugs, you'll notice, have a 5-sugar sequence that bind to the antithrombin 3, potentiating that antithrombin 3 to become more active for 10A or 2A, or equally as we see with unfractionated heparin. Now we'll go over our direct anti-factor drugs. The first class we'll be presenting is direct anti-factor 10A medications. There are 3 that are FDA approved in this class. We have rivaroxaban, branded as Xarelto, apixaban, branded as Eliquis, and edoxaban, branded as Savesa. Just as the name implies, rivaroxaban, edoxaban, and apixaban all bind directly to factor Xa within the cascade, rendering it inhibited. Whether they bind to free or clot bound, they all bind directly to factor Xa within the cascade. I will not ask specific bioavailability percentages on this assessment, but I do want you to see the differences in rivaroxaban specifically, or Xarelto. We do have to take it with food at higher dosing, so anything 15 milligrams or higher does require a high kilocalorie intake to be given along with it to ensure bioavailability. So it has reduced bioavailability when not taken with food. However, at our normal lower dosing for prophylaxis or prevention of clots in specific therapeutics, we don't have to take it with food. So there is a with or without food at lower dosing, with food anything 15 milligrams or higher. These do all have some CYP enzyme interactions, but more consistently we have PGP substrate interactions. They do have a little bit of differences between renal and liver. I won't be assessing on this, but I think this is really important information to understand as you go through the different drugs to be able to understand why some have renal dosing at different levels, why some have interactions with specific drugs versus others. You will notice with all of the direct anti-factor Xa medications that there are a number of different dosing strategies based on indication. So here you see that there are 4 different treatment indications: non-valvular AFib, VTE treatment and prevention of recurrent VTE, and then VTE prophylaxis for orthopedic surgeries. For the VTE treatment and prevention dosing, we'll see a high dose at initiation that then goes to a maintenance dose thereafter. That maintenance dose is very similar to what we see with our non-valvular atrial fibrillation dosing. With our VTE prophylaxis dosing, it is a much lower dose, and it has a specific duration of therapy based on the type of orthopedic procedure that was completed. We will go through this extensively in day 3 as well, so please note the dosing and the renal adjustment or renal avoidance issues with this medication. Xarelto had a new indication added to its labeling recently for coronary artery disease or peripheral artery disease as dual antithrombotic therapy for the prevention of major cardiovascular events. Here you'll notice that the Xarelto dosing is much, much lower than previously indicated for other conditions, and it is given twice daily. This low twice daily dose must be given in combination with aspirin, dosed at 75 to 100 milligrams once daily. There is no adjustment needed in the labeling for renal clearance. However, it is important to note that the clinical trials did exclude patients with an eGFR less than 15 milliliters per minute. The administration of rivaroxaban or Xarelto is somewhat unique to the other 2 drugs in this class. At the lower doses, as mentioned before, you may take this with or without food, whereas the higher doses, anything 15 milligrams or higher, must be taken along with food to ensure bioavailability. Rivaroxaban may be chewed or crushed, and there's actually some instructions on how it can be suspended for administration through tubes. And very unique and very cool to this medication is that you can actually double up doses when necessary. So when taking VTE dosing, which is the highest dosing available, you may take up to 30 milligrams as a one-time dose and then just resume your daily schedule thereafter. So missed doses can be doubled up within the same day to ensure the daily dosing and then resume normal scheduling on the days thereafter. Rivaroxaban, as with any anticoagulant, must be held prior to any elective invasive procedures such as surgery, and would be held until the patient maintains hemostasis after the procedure, so approximately 6 to 10 hours later. Apixaban, branded as Eliquis, was the second FDA-approved drug in this direct anti-factor Xa class. It does have reduced bioavailability compared to some of the others, but it does have standard dosing. There are interactions with PGP substrates, and it does have partial excretion through renal and liver, similar to rivaroxaban. As we get to dosing, you'll notice for all of these direct anti-factor Xa medications that they have specific dosing based on the indication provided. So for apixaban, we see first the most commonly prescribed indication is for non-valvular atrial fibrillation. Atrial fibrillation is a condition in which the patient would be at increased risk for stroke. In order to reduce their risk for stroke, we thereby anticoagulate them with fixed dosing. So here we have our standard dosing of 5 milligrams of apixaban orally twice daily. We also have a reduced dose of 2.5 milligrams twice daily when patients meet 2 of the 3 criteria listed below. So if patients are over the age of 80, less than 60 kilos, or have a serum creatinine greater than 1.5 milligrams per deciliter, they may be considered to use a reduced dose. If they meet 2 of the 3 criteria, they would reduce the dose. If they meet all 3 criteria, they would be contraindicated from receiving apixaban. Of note, it's very important that you remember that hemodialysis patients are still, according to labeling, allowed to take apixaban on any of the indications. As long as they don't meet these additional criteria, they would still be allowed to take the reduced dose of apixaban even while on hemodialysis. So that is very unique to apixaban. There's also a contraindication if the patient is already indicated to receive the reduced dose. If you wanted to co-administer it along with any strong CYP3A4 and PGP inhibitors, that would be contraindicated. So safe to use when you're using the 5 milligram, but not allowed when you have a reduced dose already. Next, we'll look at the indications for VTE. And at the top here, we see VTE treatment dosing. Treatment dosing with apixaban will be a boosted dose for the initial 7 days. So we have 10 milligrams given orally twice daily for the first 7 days. Then we reduce the dose by half and continue with 5 milligrams twice daily thereafter. So we have an initial boosted dose for the first 7 days and then maintenance dose at 5 milligrams twice daily thereafter for the full indicated anticoagulation dosing. They did reduce the doses recently for prevention of recurrent VTE. So this would be after the patient receives at least 6 months of therapy using the initial VTE treatment dosing. If they are indicated to continue anticoagulation for prevention of a recurrent VTE, we would actually use an even lower dose. So the 2.5 milligram orally twice daily was recently approved in their labeling for anticoagulation beyond 6 months following the initial treatment dosing. And we will cover this extensively again in day 3 of cardiology. But just to preview it, here it is listed in your dosing. VTE prophylaxis dosing is specific to orthopedic surgery. So specifically, we have knee replacements and hip replacements can be anticoagulated using apixaban 2.5 milligrams given orally twice daily. So this is, again, a low dose. It is just prevention of a VTE. The patient does not currently have a VTE. We just want to prevent one. So in that case, with orthopedic surgeries for knee replacement, we can give apixaban 2.5 milligrams orally twice daily for up to 12 days, according to the labeling. And if it's a hip replacement, we extend that duration out to 35 days. With VTE dosing, we do have a avoid use warning when patients are already using a strong dual CYP3A4 and PGP inhibitor. And then for administration, this may be taken with or without food. It doesn't really matter, as do most of the drugs in this packet. It does allow for nasogastric delivery. However, it needs to be suspended specifically according to that instruction there. Missed doses could be taken as soon as possible, but not doubling the dose. So if it's close to the time for your next dose, you just skip the missed dose and continue with your normal dosing strategy. Similarly, you should hold it prior to elective procedures and wait until you've achieved hemostasis before you resume it after the procedure. And that brings us to the third drug in this class, edoxaban, branded as Savesa. This is the most recently FDA approved direct anti-factor 10A to market. It has metabolisms through CYP3A4 and 2C19, and it is mostly excreted through the renal system. So it is of concern when we talk about renal dosing next. Edoxaban, branded as Savesa, is the newest direct anti-factor 10A to come to market. You'll notice that this only carries 2 of those indications, so non-valvular atrial fibrillation and VTE treatment and prevention of recurrent VTE. Both of these indications have the same dosing. However, there are different creatinine clearance cutoffs, weight-based dosing, and drug interaction considerations for the 2 different indications. Black box warning for this drug is related to the non-valvular atrial fibrillation indication, and with patients who have a creatinine clearance greater than 95 milliliters per minute, we will see reduced efficacy with edoxaban. Therefore, we should not use it in these types of patients. The VTE treatment and prevention of recurrent VTE does require 5 to 10 days of full anticoagulation with a parenteral treatment before initiating this oral anticoagulant. So patients wanting to use edoxaban or Savesa for VTE treatment would require 5 to 10 days of a low molecular weight heparin or heparin product prior to discontinuation of that drug and initiation of this oral anticoagulant at the full dose or a reduced dose based on body weight, creatinine clearance, or PGP drug interactions. For administration of this drug, it can be taken with or without food. Take your missed dose as soon as you can, but don't double it up, and just resume your normal dosing. Hold before and after post-operative procedures so that hemostasis is maintained and they're not at bleed risk during their procedure. There is no significant monitoring required for rivaroxaban, apixaban, or edoxaban. We do not actually recommend efficacy monitoring, so we do not test the anticoagulation efficacy with these lab monitors. However, we do want to monitor for safety, so we do have recommendation here for serum creatinine. That is just to see how the patient's kidneys are doing. It does not have to be done every day or every week, but we do want to know what the baseline renal function is, and throughout their therapy we may want to evaluate that. We also, as with any anticoagulation, want to make sure that we've monitored for signs and symptoms of bleeding. Up until recently, there was no reversal agent for these medications, and so included in the labeling for all 3 of these drugs, we have suggested replacement agents instead. So PCC, branded as Kcentra, is a prothrombin complex concentrate that includes factors 2, 7, 9, 10, protein C, and protein S that can be used as a replacement agent when we have bleeding with these medications or overdose of these medications. And then we also have a recommendation for recombinant factor 7, branded as Novo 7, recombinant therapy, that is also available in the labeling. Newly approved back in May of 2008 for rivaroxaban and apixaban only was the reversal agent andexanet alpha, branded as Andexa. So please remember andexanet alpha, branded as Andexa, as a reversal agent for rivaroxaban and apixaban. This has a low dose and high dose that is IV administered. You will notice the XA in the generic and brand name, so this helps you to identify that this is a reversal agent for direct anti-factor 10A medications, but only at this time for rivaroxaban and apixaban. All drugs in this packet have an ADR of bleeding, but the black box warning specific to this class is hematoma risk with epidural spinal puncture. So similar to our low molecular weight heparin, and here we have it in our direct anti-factor 10A class, there is a black box warning risk with epidural or spinal puncture, in which case we would not want to use these drugs at that time. They are contraindicated with bleeding or severe hepatic impairment. Some have even down to moderate hepatic impairment, and that would be your Child-Pugh score as you get to liver disease. They are contraindicated with strong PGP or CYP3A4 inhibitors, and then or inducers. Direct thrombin inhibitors is also, as it says in its name, directly inhibiting the thrombin within the cascade. There are 3 FDA-approved direct thrombin inhibitors in this packet that you'll be responsible for knowing. We have our oral anticoagulant dabigatran, branded as Pradaxa, is our only oral direct thrombin inhibitor. We have bivalirudin, branded as Angiomax for PCI, which you'll get to with Dr. Bhakta, so for percutaneous coronary intervention. And we have our Gatraban, which we'll learn about can be used as an anticoagulant in the presence of HIT. All 3 of these drugs bind directly to thrombin factor 2A within the cascade, and they're all derived from the natural anticoagulant found in leeches. Dabigatran, branded as Pradaxa, will bind and reversibly inhibit thrombin through free and clot-bound thrombin. Not important that you really remember which ones are free or clot-bound binding, but there are some differences between these drugs. When we look at dabigatran etexylate, that is how it's packaged in formulation. It is a prodrug that is immediately converted to dabigatran within phase 1 metabolism, so we don't usually have interactions with that. It's phase 1. We have plenty of ability to hydrolyze medications, in which case dabigatran etexylate is what is formulated. The patient ingests it, immediately goes through first pass metabolism, and is hydrolyzed into dabigatran active drug. It has low bioavailability orally, however, that is how we administer it. It is in a very specific, unique capsule formulation that is a pump. So if you open, chew, or crush that capsule, you get significant increase in bioavailability, which puts the patient at severe risk for bleed. So you don't want the patient ever to chew, crush, or open their capsule. It has renal clearance, and so we do have a renal adjusted dose in one indication. Pradaxa is FDA approved for both non-valvular atrial fibrillation as well as VTE treatment and prevention of recurrent VTE. You'll notice that the dosing is very similar. So we have the 150 milligrams given orally twice daily. That is the same dosing for both, but the renal adjustments are very different. With the non-valvular AFib, you'll see that it also has different adjustments for drug interactions. And then when we get down to VTE treatment and prevention of recurrent VTE, we have the 150 milligrams orally twice daily, same as the non-valvular AFib. However, preceding this, the patient must have received at least 5 to 10 days of parenteral anticoagulation before they can switch over to dabigatran. So similar to edoxaban, Savesa that we just talked about, which was our oral direct anti-factor 10A medication, before you can initiate either of these 2 drugs, they must receive 5 to 10 days of parenteral, that means subcutaneous or IV anticoagulation, before they can switch over to this oral 150 milligrams of dabigatran administered twice daily. There is renal adjustment as well as the drug interaction adjustment, so just be cautious with that, and we'll cover this again in day 3. ADRs include bleeding, and then we have a black box warning similar to the previous drugs that we've talked about, where there's hematoma risk with epidural or spinal punctures. We don't like patients to bleed into their spine, so we try to avoid epidural or spinal punctures while they're taking Pradaxa. It is contraindicated in bleeding, which makes sense. And then mechanical heart valve was related to a trial where dabigatran was attempting to gain the indication of mechanical heart valve, and patients were having fatal bleed and fatal clotting, all in one. So contraindicated in mechanical heart valve. There is a reversal agent currently available for dabigatran. We learned this last year that we can administer Praxbind to patients who are having life-threatening bleeding while taking dabigatran. Praxbind is available as a reversal agent for dabigatran. It is specific to just dabigatran and does not carry over into any other drugs in this class. When we administer dabigatran, there are significant counseling points. So you should know and note to the patient that they should store in their original packaging. They come in a container or a vial, as well as they come in unit dosed packaging. So if the patient wants to take them out and put them into pill organization products, then you would not be able to do that with the original vial where there's a desiccant in there, but you could do that with their unit dosed blister packs. So if they have blister packs, they can tear those into one individual dose per day or per dose and then put that in their pill organizer that way. However, you cannot take them out of their original vial that they're distributed in, so you should never partial this order unless you have unit dosed packaging. Once it's opened, that original vial with the desiccant lid must be used within 4 months. So anything that gets opened must be used within 4 months, and do not chew, crush, or open those capsules. As we mentioned before, that increases bioavailability and significantly increases the patient's risk for a bleed. Missed doses can be taken as soon as they recall. However, they should be at least 6 hours apart from their next scheduled dose, or they should just skip that missed dose and continue on with their routine scheduling. We hold it prior to invasive surgeries and then resume it once hemostasis is achieved post-procedure. Bivalirudin, branded as Angiomax, will be discussed in detail with Dr. Bhakta's material, so please stay tuned for that. However, we should know that this is a direct thrombin inhibitor medication, and we should know where in the cascade that blocks. Argatroban is the third and final direct thrombin inhibitor that you'll be responsible for knowing. We will go over this in detail as it is a treatment option in heparin-induced thrombocytopenia HIT-positive patients, and you'll also cover this again later as you get to other cardiac conditions. It is given IV, as is bivalirudin. These are both IV-only formulation. It can be used in PCI, and specifically for this assessment and for our understanding in the treatment of HIT, we would prefer to use argatroban in a HIT-positive patient. So a patient who has experienced heparin-induced thrombocytopenia, they have an elevated 4T score, they may have confirmed with an ELISA test or with an SRA test, then we would immediately discontinue their heparin product and we would initiate argatroban. Argatroban is dosed as a continuous IV infusion. That is, the minimum initial dose is 2 micrograms per kilogram per minute, continuous IV infusion, and then they titrate this dose to obtain 1.5 to 3 times the baseline APTT with a maximum dose of 10 micrograms per kilogram. There are hospital protocols that are used to adjust doses, and nurses should be familiar with these, as well as pharmacists should be able to educate on these within their facilities. Argatroban we know that it's working on the thrombin within the cascade, and in which case it can unreliably elevate the INR. So when we are converting to warfarin, there are specific regulations surrounding that, and we know that the INR will be elevated, and we plan for that and dose around it. There are ADRs of bleeding, like there are with all the other drugs. Let's spend a little bit of time understanding how to manage a patient who comes in and has suspected heparin-induced thrombocytopenia. So your patient has come into the hospital and they have received a heparin product, whether it be unfractionated heparin or low molecular weight heparin. If the patient is naive to heparin products, having never seen them before, the patient would have a delayed reaction where their thrombocytopenia would occur at about day 5 to 10. If they have a re-exposure of heparin, so they've had a heparin product in the last 90 days, they continue to have those memory cells, so then they will have an immediate response of thrombocytopenia. We can confirm that with a 4T score. So we look at the thrombocytopenia, the significance of the drop in their platelet count. We look at the timing surrounding their medical history and introduction of the heparin product. We also look at the thromboses to see if they're exacerbating their existing clot or expanding that clot, or have generated new clots in the body. And then fourth, we look at any other potential cause for that thrombocytopenia. If their 4T score is elevated, we can confirm that. We do not have to, but we will likely confirm that with a laboratory test. That can be an ELISA test to check for the antibody complexes. So that's the PF4, heparin, IgG antibodies. Or we can do an SRA test to confirm actual hit. If they have suspected or high probability for hit, we're discontinuing that heparin product and immediately converting them to an alternate anticoagulation therapy. Whatever anticoagulants they are on at the time, we would discontinue, whether it be heparin products or maybe they were bridging onto warfarin. We discontinue all other anticoagulant products and we initiate argatroban. Argatroban is our continuous IV infusion. It is initiated at 2 micrograms per kilogram per hour, or per minute, 2 micrograms per kilogram per minute, and adjusted to obtain an APTT of 1.5 to 3 times their baseline APTT. Once we've initiated that argatroban, we wait until their platelet count is resolved. So they'll probably be getting daily CBCs where we get a platelet count. Once we see that platelet count resolving, we can initiate warfarin. We don't want to keep them on argatroban forever because it's very expensive and it does require frequent monitoring. So if we can avoid that, we would like to convert them back over to warfarin, which is safe to use even in a HIT-positive patient. So we start the warfarin, and here we have concomitant use of 2 anticoagulants. So we reduce the dose of argatroban, whatever dose they were on before, we reduce it to the minimal dose that we initiated at the beginning. So that's 2 micrograms per kilogram per minute IV infusion with warfarin concomitant at the same time. We would want to continue this co-administration of both warfarin and argatroban for at least 5 days, and we're targeting an INR range above 4. Recall that argatroban can elevate PTT or PT, which will then elevate our INR, in which case we're expecting it to be higher than what it would be with just the warfarin alone. So we do require 5 days of bridging, similar to any of our anticoagulation therapies going over to warfarin, and the INR must be greater than 4. So we can adjust the dose of warfarin through those first 4 days just to make sure, or 5 days, just to make sure that they're getting the right INR therapeutic goals. At that point, if we've obtained 5 days of concomitant use of both anticoagulants and have achieved an INR greater than 4, we would hold the argatroban. So we turn off that continuous IV infusion for 4 to 6 hours. At 4 to 6 hours after we've terminated the argatroban dose, it is no longer affecting the INR, so we check INR. If their INR is greater than 2, we know that that's therapeutic, and we can just continue with the warfarin. We're happy. They can go home, and they're going to be anticoagulated. If their INR is less than 2, that would be subtherapeutic, in which case we do require that parenteral anticoagulant to be turned back on. So we turn back on the argatroban at the 2 micrograms per kilogram per minute and continue the warfarin, potentially adjusting the dose or just waiting until their INR is stable at above 2. When we put back on the argatroban and the warfarin together, we are looking for that INR to be elevated to above 4 in order for the warfarin to be expected to be above 2 on its own. The last class of anticoagulants that we'll talk about is certainly not the least. It is the absolute most common anticoagulant prescribed and utilized throughout the world. This is our vitamin K antagonist class. In this class of medications, we have warfarin. There are 2 brand names that are readily available in the United States, the most common being Coumadin, and the second being Jantoven. They both have the same color of their dosing tablets, so whether it be generic warfarin sodium, branded Coumadin, or branded Jantoven, the color of the tablet reflects the dosage of that tablet. These all work, or these warfarin sodium works, to block the activity of that vitamin K epoxide reductase enzyme that is required in the reduction of vitamin K to its active form. Reduced vitamin K is required in the formation of factors 2, 7, 9, 10, protein C, and S. So I commonly talk about how 1972 was a really good year. 1972, that is 10972, but you can't forget the protein C and S. Another way that I refer to this is SNOT, S-N-O-T. S stands for anything that sounds like an S. So that's your factor 7, your protein C, and your protein S. These die off really rapidly within the day. Their half-lives have expired. So they die off pretty quickly when you initiate warfarin. Then we have factor 9 sticking around a little bit longer. O stands for factor 10, that takes a little bit longer than 9. And then we have factor 2, or T, is our last factor to expire. This factor, factor 2 or thrombin, is at the bottom of the cascade. It is the step that does activate fibrinogen to fibrin, in which case, as long as there's factor 2, we know that we're clotting. So there is a delayed onset of action for warfarin related to the expiration of the circulating factors already available within the blood. So if we block the formation of these drugs, or the formation of these factors in the liver, the drug does delay its onset of activity because we have circulating factors, factors S, that's 7, C, and S, all die off rather quickly. Factor 9 or N takes a little bit longer, factor 10, and then lastly, factor 2 can be around for as many as 5 days. Here we see an image of how warfarin has two enantiomers. We have the most active being the S enantiomer, depicted by the large arrow here, and we have the R enantiomer, less active but still potential interactions there. And we have a number of pharmacokinetic interactions. We have 2C9, we have CYP1A1, CYP1A2, CYP3A4, so a number of potential interactions pharmacokinetically. These are blocking the vitamin K epoxide reductase, which may have different variations. So we also have pharmacogenomic interactions with our V-core activity. And V-core is responsible for reducing vitamin K to its active form over here. If we inhibit vitamin K epoxide reductase, we are inhibiting the formation of reduced vitamin K. That reduced vitamin K is required in the formation of factors 2, 7, 9, 10, and we can add protein C and S there. So we have functional factors 2, 7, 9, 10, protein C and S being blocked by our vitamin K epoxide reductase enzyme. The pharmacokinetics are listed here more as an FYI, but to understand that it can take up to 8 to 15 days to see steady state achieved. That is because of those vitamin K dependent factors and their half-lives towards expiration. We also see that there are significant potential interactions pharmacokinetically, and we are familiar with some of those drugs. It is contraindicated in pregnancy, so we should not use this in pregnant women. So here we have a pictorial image of what we just talked about. We have factor 7, protein C, and protein S all dying off, expiring rather quickly. We have factor 9, so that's the N, expiring shortly thereafter, factor 10 right behind, and then factor 2, or T, lasting for days following initiation of warfarin. So it does take about, as you see down here, it does take about 5 days in order for warfarin to achieve steady state. Once warfarin has achieved steady state, we have an expected drop-off of our factors, and that will obtain an INR that is therapeutic in that 2 to 3 range, or higher if necessary. All indications are approved for the use of warfarin, including mechanical heart valve, which is unique to just this one oral anticoagulant. The only oral anticoagulant that we can use in mechanical heart valve is warfarin. There are some unique ADRs with this. It can cause tissue necrosis. It can cause hypersensitivity, which is rare but can occur, especially with the dyes and the different dosing. It can cause hemorrhage, interocular hemorrhage, rare but serious, and then cholesterol embolus syndrome. So what happens is as we're initiating the warfarin, we can reduce the capsule size on our atherosclerotic plaques, and in doing so, we can actually induce a little bit of clotting initially. Those tiny little clots will lead to potential risk for tumor tissue necrosis and cholesterol embolus syndrome. We do monitor warfarin with INR, which we've talked about extensively in your P1 year, so please recall that. We evaluate by calculating an INR from their obtained PT. So PT is the time to clot. We introduce tissue factor and other calcium into your plasma sample, and we look for the clot. So we're tracking the pathway from extrinsic down through the common pathway to the fibrin strand. In doing that, our PT will vary based on the reagent that was used to obtain that. So if we used one manufacturer's tissue factor to obtain the PT, that may have a different PT variability from another manufacturer's tissue factor that was added to the plasma sample. So we do what's called an INR. It's a normalized ratio that raises the calculation compared to control to an international sensitivity index. Every single one of our reagents has a different international sensitivity index. So your laboratory will do this calculation for you. You don't need to be able to calculate this on your own, but you should know that you draw a PT and the calculation for INR is reported at the same time. So the benefit of that is we can reliably dose based on the INR. We can not reliably dose based on PT. We must have a normalized ratio in order to accurately dose our warfarin. So in monitoring with INR, we're looking for a therapeutic INR in our warfarin-based patients. If the patient was not receiving warfarin, we would expect their INR to be approximately 1. If they are being dosed warfarin, our typical target is 2.5. So their INR goal is 2 to 3. If they have a mechanical valve in the mitral valve position, so that is the left side of the heart separating the chambers of the left ventricle from the left atria, if that valve is impaired and they have to have it repaired and have a mechanical mitral valve replacement, then they have what's called a high goal. Their target becomes 3 and their INR goal is 2.5 to 3.5. That is the only high goal that is indicated in the guidelines. Physicians can always pick whatever targets they would like to have their patient anticoagulated to. However, if we're following evidence-based medicine, all patients require an INR goal of 2 to 3 for potent anticoagulation. And if they have a mechanical valve specifically in the mitral position, then we're looking for a high goal of 2.5 to 3.5. Warfarin dosing generally begins at 5 milligrams once daily. It can be lowered in specific populations. Think about our severe elderly or someone with severe liver disease. We may adjust that dose down. Dr. Bakhta will also talk about loading doses and how we can use those in the guidelines. But we know that it does take some days for this INR results to be reflective of the warfarin dose, and it can take as much as 8 to 15 days to see the full steady state effects of that dosage change. So we can't expect a dosage change to be reflected in the first day or two following that change. We must wait, and we may wait up to 2 weeks to see the full impact of that dosage change. Warfarin sodium, as you'll recall, has significant interactions with a number of different substances, including drug, disease, and lifestyle. Here we see a list of a number of those drug interactions, mostly related to the 450 metabolism, so CYP450 metabolism. However, some are separate from that. So we have amiodarone, the most notable or notorious interaction. It does have a delayed interaction, so it has a partial immediate response and then a delayed up to 6 weeks interaction that will eventually elevate the INR significantly. Amiodarone is so potent that we go ahead and reduce the dose of warfarin if we're going to initiate amiodarone, or if we're initiating warfarin in a managed amiodarone patient, we may pick a lower initial dose of our warfarin, knowing that there will be an interaction within weeks. A lot of your antibiotics will print out auxiliary labels concerning warfarin and antibiotic interactions if the patient's on warfarin. However, there are specific medications that you should be familiar with. So our sulfamethoxazole in the branded product Bactrim. So we have sulfamethoxazole, trimethoprim is Bactrim, or levofloxacin. These are more common antibiotic interactions. Our sulfamethoxazole is so potent in its interaction with warfarin that, similar to amiodarone, we do a standard dose reduction when we're initiating warfarin, or when we start the patient on chronic use of Bactrim, then we would decrease the dose of warfarin, anticipating this interaction to elevate the INR. Antifungals include our fluconazole, ketoconazole, itraconazole. These all are going to interact and cause the INR to be affected. We have our anti-epileptic drugs or anticonvulsant medications. These are interacting with warfarin as inducers. So we have phenobarbital, phenytoin, carbamazepine. Steroids, including methylprednisolone or prednisone or other oral systemic steroids, can elevate the INR. We have simvastatin, which can elevate the INR. We have a number of our chemotherapeutic agents that will impact the INR, as well as aspirin. Aspirin and NSAIDs do not interfere with the INR reliably, but we do know that they have antiplatelet activity. So if you have an antiplatelet activity drug and you're administering it along with an anticoagulant, you know that you're at increased risk for bleeding. So that's what the interaction is related to. Acetaminophen, although it is our preferred OTC pain reliever when they're using warfarin, can cause an elevation in the INR, specifically in our liver impaired patients, since it has competitive inhibition of the function of the liver. So if we have high doses of acetaminophen, that can affect your INR, as well as if the patient has severe liver disease and we go ahead and give them acetaminophen along with their warfarin, we may notice an increase in their INR. We have a number of herbals or supplements that can impact the INR. Most notably, we have St. John's wort, which is an inducer. And then we have vitamin E and fish oil and garlic, which all have antiplatelet activity. Red clover, that is where warfarin came from, so it also has antiplatelet activity and anticoagulant activity. And then we have multivitamins that do contain vitamin K. So this list is extensive, but it's more about just making sure that you understand which interactions are most common and how they affect the INR. We have food interactions. When we think about food interactions or even beverage interactions, we're looking at the vitamin K rich foods. So if they're over consuming them, we know that they're going to have more vitamin K, in which case that would lower their INR and they'd need a higher dose of warfarin. If they cut out all their vitamin K when they were on a vitamin K rich diet before, then we would notice an increase in their INR as there's not as much vitamin K to overcome. Drug disease interactions are listed here, and you can reason through all of these, including the last but not least, bowel syndromes. If they have chronic diarrhea, they may have decreased transit time, so decreased ability to absorb the warfarin, as well as decreased transit time of their foods, so they have decreased ability to absorb their vitamin K. So this is an unreliable interaction where you can get either high or low INRs or erratic INRs. Let's go ahead and work through some of those interactions by filling them into this table. In the center, we have a therapeutic INR of 2 to 3. That's your average patient. If the patient has a mitral mechanical valve, we know that that would be a 2.5 to 3.5 range goal. But here we have a therapeutic INR of 2 to 3. So if they take their dose as prescribed and it's the right dose, we would expect a therapeutic INR. If they miss or decrease dosing of their warfarin or Coumadin, that will cause a lowering of their INR. There's not enough warfarin to keep the INR where it's therapeutic, in which case it puts them at higher risk for clotting. If they increase or accidentally take extra dosing or intentionally take extra dosing, that will cause an increase in their INR, putting them above 3, which increases their risk for bleeding. There's consistency in diet that should be counseled upon. So if they're consistently eating about the same amount of vitamin K in each day over the course of the week, they should have a therapeutic INR. Of course, if they increase their green leafy vegetables or the tea that they're consuming or the cilantro that they're consuming or some other contributory effect on their vitamin K increase, then that will decrease their INR. If they decrease or eliminate the vitamin K from their diet, let's say that they were eating a lot of kale and they got sick of it, so they stopped eating the kale, in which case it would decrease their INR or decrease their vitamin K intake, thereby leading to an increase in their INR. Another common vitamin K intake form is in the form of a multivitamin. A lot of patients will take a daily multivitamin that does have a little bit of vitamin K in it. That is okay as long as it's the same manufacturer, the same dose every day. If they, however, pick a new manufacturer or they initiate multivitamin use and there's vitamin K content in those multivitamins, it can lead to a drop in their INR. And then if they stop their multivitamin or they ran out, it will cause an elevation in their INR. Consistent alcohol intake is recommended. It's not that you have to drink alcohol. If they're abstinent, that's completely fine. We would prefer that. However, in a patient that does consume a little bit of alcohol or a lot of alcohol, it's more important that we counsel on the consistency of that alcohol. And of course, we want them to reduce their alcohol intake to a recommended amount of 1 to 2 beverages a day, no more than that. However, based on what they're currently doing, as long as they're consistent, it won't affect their INR. If they decrease or they abstain from alcohol for periods of time, that will cause a decrease in their INR. And then opposite, if they increase their alcohol intake, whether it be through binge drinking or increasing consistently, it will cause an elevation in their INR. Of all the interactions, alcohol actually occurs really rapidly. This interaction is partaking in the liver, so instead of modifying the formation of the factors like the other interactions, this is actually competitively inhibiting the warfarin from working effectively. So alcohol versus warfarin, it occurs really rapidly. So this can occur within a couple days of the alcohol intake, whereas the others can occur over days. So alcohol intake will modify the INR within 1 to 2 days or longer, and then dosing and diet may take a few days to actually see that interaction. Another interaction that is part of their social history would be their smoking history. So smoking will induce the CYP enzyme at the 1A2 enzyme. So if it's inducing the enzyme, the more that we smoke, the more we're metabolizing warfarin. If we increase their smoking, it's going to cause a subtherapeutic INR. If they decrease or abstain from smoking, they go through smoking cessation, which we would love them all to do, that will elevate their INR, meaning that they need less warfarin to stay in that therapeutic range. Ideally, they're not having very many medication changes, but we know that not to be the truth. In most of our population, we have medication changes all the time, especially in our elderly population, which will be the majority of our patients using warfarin. There are inducers, which will induce the metabolism of warfarin. So these are pharmacokinetic inducers through the CYP enzymes. We have rifampin, phenobarbital, phenytoin, carbamazepine, and the nutraceutical St. John's wort. These will all work to increase the metabolism of warfarin, thereby lowering the INR. In opposition to that side, we have our pharmacokinetic inhibitors. These are drugs that will inhibit the metabolism of warfarin, thereby causing an elevation in INR. We have our notorious amiodarone and Bactrim. Those will, in chronic use, consistently cause an elevation in their INR, so we may even automatically adjust the warfarin dose anticipating those interactions. Recall that amiodarone may take up to 6 weeks to see the full interaction. Bactrim's a little bit more rapid than that. Azole antifungals include our most commonly prescribed fluconazole, ketoconazole, itraconazole. All of our azole antifungals can cause an increase in INR. Simvastatin is one of the statins that can be prescribed, and it is the only statin that's listed here. It is a potent CYP enzyme inhibitor, so we have INR elevations with simvastatin use. Systemic steroids can be used consistently or chronically over time, so any of our chronic medications should be dosed around. If it's a one-time, like I'm giving you a steroid shot, it's going to last a few days, I don't need to dose around that. Again, if it's not systemic, so if it's an inhaled corticosteroid or an intranasal, intraocular steroid, we don't have to concern ourselves. However, if they're chronically using that steroid, similar to any of the other drugs in this list, we must reduce the dose of the warfarin in order to maintain a therapeutic INR. Last on this list is ritonavir. There are 2 HIV-PI inducers, so we have protease inhibitor inducers that are inhibitors that are inhibiting the breakdown of these PIs, so we know that that's also going to break down or block the breakdown and metabolism of warfarin as well, so we will accumulate warfarin, causing it to have an increase in the INR. There are a few drugs that I want you to also be familiar with. They're listed here in the middle in red. These drugs have antiplatelet activity, whether they be an actual medication or a nutraceutical product that can be commonly consumed by OTC from the OTC aisles. These have antiplatelet activity. So antiplatelet activity is not going to impact the clotting cascade, in which case we're not going to get therapeutic changes to our INR. Our INR will not be affected by these drugs consistently. They can cause elevations, but they don't always cause elevations. So even more concerning, if they're having antiplatelet activity, that would put them at increased risk for bleeding because they're using both an anticoagulant, warfarin, and an antiplatelet, as listed here. So they may not get a change in their INR, but they're still at higher risk for bleeding. So we have included in this list aspirin, which we know is a potent antiplatelet medication. We have NSAIDs, or non-steroidal anti-inflammatory drugs. That includes ibuprofen, naproxen, diclofenac, and the like. Fish oils, garlic tablets, and vitamin E oil. These are commonly used OTC products that will increase the bleeding risk without increasing the INR, so it's a dangerous mix. You may notice that aspirin in fish oil can be recommended even in these patients that are taking anticoagulants. So they're not an absolute contraindication, and they're actually, in some cases, recommended in the therapeutics of the patient. However, you should be able to counsel on the risks of the signs and signs and symptoms of bleeding or bruising, as well as the risks of clotting if their INR is going low. So you should counsel the patient on what to look for with signs and symptoms of clotting. That includes symptoms of a stroke or a VTE, which we'll talk about in day 3, VTE, venous thromboembolism. Or if it's elevating their INR, it's putting them at increased risk for bleeding, or if they take aspirin, NSAIDs, fish oil, garlic tablets, or vitamin E along with their warfarin, it can increase their risk for bleeding, in which case we'd counsel them on the signs and symptoms of bleeding. They may also experience bleeding at any INR, so they should always know what the signs and symptoms of hematochezia are, that coffee ground emesis, whether it be bright red blood or the coffee ground emesis appearance of the blood in the gastric juices. It could also be frank red blood in the bowel, or melena, which is that black tarry stool that maps the toilet as they flush. Those are all counseling points on what to look for, as well as blood in their urine. So these are common signs of bleeding that we would want our patients to be familiar with. Genomics is a newer area of concern, and you've learned this already with Dr. Rollins. He talked about different pharmacokinetic and different pharmacogenomic interactions with certain drugs, and warfarin is the most commonly used example of a pharmacogenomic interaction. There are variations in their VCORC1, which is the genetic makeup of our vitamin K epoxide reductase complex. This vitamin K epoxide reductase enzyme is used to break down that vitamin K into its reduced active form, in which case any mutations can lead to variations in the warfarin effectiveness. So this can lead to warfarin resistance or warfarin sensitivity. And we don't commonly genetically test for the VCORC1 variations. However, there are labs available that will determine based on your VCORC1 what your initial doses of warfarin or your maintenance doses of warfarin are expected to be. And they're pretty accurate, so that's a pretty interesting change that is coming to market and is readily available. However, it's not readily used, and it's certainly not recommended in the guideline, just due to cost and the turnaround time and things. We also can have genetic variations in our metabolism. So we have differences in the way that our CYP2C9 enzyme can affect the metabolism of warfarin. So based on a patient's CYP2C9 activity, that can lead to either increased or decreased warfarin effects. As stated, the recommendations to genetically test for these variations is not recommended in the guideline. However, they are available, so that's of interest. Typically, when we talk about reversal agents, we're talking about antidotes to overdosing our drug, and that they generally bind to that active drug to render it inactive. In this case, however, when we talk about our reversal agent for our vitamin K antagonist warfarin, we're actually talking about vitamin K. And we know that warfarin works by blocking the reduction of vitamin K to its active form. And here, when we give vitamin K, we're overcoming that mechanism by just introducing more vitamin K into the system. This can be used for a multitude of reasons. However, in this case, we're using it as a reversal agent for overcoming the effects of the warfarin. There is a black box warning for severe shock and anaphylaxis. This is related to IV and intramuscular injections. So then when we talk about the administration of this phytonadione, we do have preferred routes of administration. Our most preferred would be either a tablet or an IV solution that's given orally that has low risk for this shock or anaphylaxis, in which case they're just consuming the vitamin K orally. That will go through first pass metabolism as soon as it's absorbed. So it does get to the liver relatively quickly to start allowing it to work. However, even faster onset would be our IV formulations. Unfortunately, IV formulations carry a risk for anaphylaxis, in which case they're really only used in life-threatening bleeding. So our preferred route of administration is oral. We may also administer it IV, considering that there is a risk for anaphylaxis. Subcutaneous administration should be completely avoided. It is allowable. However, it has very variable absorption patterns when we give it subcutaneously, so it is absolutely not recommended and should be avoided. And IM carries too high of a risk for that anaphylaxis and cardiac shock, so we do not want to administer it intramuscularly. Provided for you here is a table surrounding the guidelines of when to use vitamin K in overcoming INR elevations. If the patient's INR is elevated slightly, we do adjustment of dose, and we'll talk about that extensively on day 3 of cardiology, which will be a ramp up from what we learned in our P1 year. But here we have an INR elevation that's pretty elevated, between 4.5 to 10 with no bleeding, and in which case we do want to hold the warfarin dose, but we don't have to administer vitamin K in this population. So if there's no bleeding, even with their INR going up as high as 10, we just hold the dose of warfarin and wait for it to resolve. We may resume the warfarin at that time at a reduced dose, or consider an alternate anticoagulant, or remove the interaction that's causing that elevation in the INR and go from there. If their INR is greater than 10, that would be a severe elevation. But if they don't have any bleeding, we still give the vitamin K, but it's not in a formulation that's immediate, right? So here we're holding the warfarin and we're giving oral vitamin K at low dose. So if it's over 10, that sounds like a really high number, but if there's no bleeding, it's just hold the warfarin and give oral vitamin K at a reduced dose. If at any point in time they experience major bleeding, regardless of what their INR is, we're going to hold the warfarin dose, give IV phytonadione, and concentrated factors. So we have PCC. We hold the warfarin, we give IV phytonadione, and give concentrated factors. Most commonly now is Kcentra.